Welcome to this luncheon on a very, very important topic, and it's an honor for myself to be here in this responsibility as chair of this event. And I will continue with the presentation. Since 1997, the Forum Fronterizo has been examining issues of significant importance to the sustainable development of the San Diego, Baja California region. We are looking forward to our ability to make progress on the issues that are critical to the future and joint development of our cross-border region. The Forum Fronterizo is the culmination of the goodwill, wisdom, and efforts of many Mexicans and Americans, not just one person or organization, but each and every one of you. We are dedicated to the serious discussion of the major bilateral issues that face us every day and shape our future together. We all believe that these exchanges are one way to build consensus on the solutions to the challenges that face the region. I want to extend a heartfelt thanks to all of our sponsors of this year's Forum Fronterizo series. We are thrilled at this wonderful civic leadership from both sides of our border. I would also like to recognize and thank the Border Health Education Network at UCSD, which is doing a terrific job at promoting cooperation between San Diego and Baja California in the field of trauma and emergency health care, and has also played a key role in making today's forum possible. Thank you very much. Our program today will address public health preparedness and emergency response in our binational region. A good system of public health care is essential to the well-being of our region. Since disease and emergencies do not recognize political boundaries, we must complement efforts on each side of our border with strong binational cooperation initiatives, such as the one my government is developing with the state of California. The forum is an excellent opportunity for the community to learn about recent efforts to improve emergency and trauma health care in our region. To do so, we have gathered the exceptional group of specialists in the subject. Our topic will be introduced and moderated by Dr. Jorge Flores, health consultant, and until very recently, the public health officer of San Diego County. Dr. David Hoyt, head of the trauma division of UCSD Medical Center, will speak about the state of emergency and trauma health care in San Diego. Dr. José Magallagoitia, secretario técnico del Consejo de Accidentes y Lesiones de Baja California, will talk about the progress of my state in this field, as well as about some of the binational cooperation efforts currently underway. Dr. Steven Waterman, U.S.-Mexico border epidemiologist for the U.S. Health Centers for Disease Control and Prevention, CDC, will talk about progress and challenges in the fight against infectious diseases in our region. The closing speaker will be Dr. Francisco Vera, Health Secretary for the state of Baja California. Following his presentation, the discussion will be open to the audience. Please now take the next few minutes to enjoy the rest of your lunch and to visit with your colleagues. Le doy la bienvenida.
I'd like to welcome all those individuals from Baja California. We're very pleased that you're here with us today at this very important meeting regarding public health and how prepared we are to confront any critical issue. We hope that this topic offers us an opportunity such that with the support which we find by working together, referring to authorities and communities on both sides of the border, that we might be able to progress even more in this high priority issue. Bon appetit, and I hope that your presence today tends to enrich our knowledge of the
I'll be
subject.
seeing you in a few minutes. Thank you.
Muy buenas tardes a todos. Good afternoon to everybody. I'm Dr. Jorge Flores, and I'll be your moderator. With respect to the time, because of our late start, we are going to go ahead and proceed with our presentations. We would like you to enjoy your lunch while the presentations are being done. I would first like to begin by welcoming all of our counterparts, our esteemed counterparts, nuestros contrapartes estimados de Mexico, because of your long border wait coming across. Yesterday I was coming across from Mexico, very long and hot time in line, and I know that you all must really want to be here with us, and I thank you for enduring that so that we can be together for this luncheon today. We have long recognized the need for and challenges to improving public health preparedness and emergency response in the binational border region. The events of September 11 and following have served to accelerate our attention to matters involving security, the security of having an emergency medical system with well-trained and highly skilled workforce, advanced equipment and accessible facilities, rapid response to and transportation for the sick and injured, fail-safe and broad communication systems, both to the medical community as well as to the public in general, and an extensive collaboration between all parties, meaning not only here in the United States and in Mexico, but across our borders, and with our public and with all of the entities that must be involved in our security and our safety as a people here in the border region. We're here today to address these timely and important issues as they affect the well-being of all of us. We expect that today's dialogue will answer some burning questions, raise some new ones along with new ideas for solutions, such as what does it take to save lives, prevent disability from traumatic injury, or the spread of highly communicable disease? How does public health preparedness and emergency response in Mexico compare to that in the United States? How can we work together to assure the best possible outcome when we're involved with a very, very highly contagious disease or with injuries that are causing havoc with people who are driving or receiving injuries on the road, or perhaps even illness and needing a quick response when we have a system that is taxed and very much in need of a boost to respond to all of the demands from modern society? Well, we have some great presenters for you today, as you've heard, and so let's get going with the presentations. I'm going to introduce first Dr. David Hoyt. Dr. Hoyt is the Monroe E. Trout Professor of Surgery at University of California at San Diego. He currently serves as Vice Chairman of the Department and Chief of the Division of Trauma, Burn, and Surgical Critical Care. In addition to an active clinical schedule, he's intensely involved in graduate and undergraduate education. He's currently President-elect of the American Association of the Surgery of Trauma, past President of the Society of General Surgeons of San Diego, Secretary and President-elect of Shock Society, past Chair of the American College of Surgeons Committee on Trauma, and currently Medical Director of Trauma of the American College of Surgeons. Dr. Hoyt's authored over 325 publications. Please welcome Dr. David Hoyt.
Thank you, George, and I'd like to thank Elizabeth and the planners for the opportunity to share something that I think is really, really important to San Diego. I've lived here for 25 years, and I've often hoped that we might be able to do something that's occurred in the last 2 years. And it's really many of the people here in the audience that I'll try and point out that have made this possible. We're going to talk specifically about trauma care, and I'm sorry about the fact that you're eating lunch, but I think you need to understand what trauma care is all about. It could be you roll over in a car. It could be you going home with a pizza and minding your own business and oops, pedestrian struck, one of the most common mechanisms. It could be a NFL game in San Diego Stadium. People disagree, and that's what leads to trauma. Now, it turns out that it's the leading cause of death between the ages of 0 and 50 in this country. It leads to more years of life lost than cancer, heart disease, and stroke combined. And for men, based on a new study that's just come out of the Harvard School of Public Health, it is now the second leading cause of death overall. It's about $250 billion per year. And it's really only in the last 35 years that we have approached this in the United States as an epidemic. And this white paper that you see there is the white paper that started it in 1966 in the United States. Now, through national databases, and this is the National Trauma Data Bank, we can continue to stay focused on the profile of the youth that are subject to trauma. But as you can see, there's an emerging peak of elderly trauma that we're seeing in San Diego and we're seeing throughout the world. And this is a disease that as we age, because of a better healthcare system, we're going to continue to have problems with. Now, traditionally, a trauma care system, which is really my charge to talk briefly about today, is a locally coordinated approach. And it involves identifying patients in the field, putting them together into hospitals that can care for them, and providing optimal care. And when you look at when patients die, they die immediately at the scene, and that requires a strategy of prevention. They die in the first several hours, and that's the focus of trauma systems and trauma centers. And then they die later on, which is really the focus of the intensive care unit. And what we're really initially focused on is the so-called preventable death, or the golden hour, and it's really this that's the focus of trauma centers and pre-hospital care. Now, in San Diego, we've been fortunate for the last 18 years to have a very stable, integrated system. It's truly a public-private partnership. This was developed based on a needs assessment in 1982, and since 1984, the citizens of San Diego have benefited from this system. It includes pre-hospital providers, paramedics, EMTs, the fire service, medical direction, communications, including a 911 system and additional communications, and then the sorting of patients that need trauma centers and the transport to the trauma centers. A trauma center is literally a hospital that's capable of taking care of every injury, and it involves many specialists, all kinds of nurses, and essentially every other staff member. Now, that's what we have in San Diego today. It's based on a set of quality care standards that are national in origin, and it has been demonstrated recently by a national consensus conference that, in fact, the implementation of a trauma system leads to a reduction in preventable death of about 8 to 10%. And, in fact, that's exactly what we enjoyed in San Diego in 1984 when this system was put in place. Prior to that, there was a preventable death rate that was in the area of 20%, and it's been reduced and currently remains less than 1% because of the dedication of all these people. Now, it also, and it is more important today to also understand the relationship of a trauma system to mass casualty management, and even including bioterrorism. The infrastructure is really there for mass casualty management with a trauma system. Now, historically, we have had many attempts over the last 20 years to develop exchanges, both with pre-hospital care, didactic conferences, the introduction of ATLS, which is a national program for the development of trauma care. We have assisted at times with designing emergency departments, but we really were not very progressive, and we recognized that we had a number of problems, but we were really never able to overcome some of the impediments. Perhaps for a lot of reasons, not the least of which is an increase in business exchange, the increase in tourism. Perhaps we're just better neighbors, but we've now been able to start to overcome some of the barriers, which in the past included we didn't really know each other, we didn't communicate very well, we had inconsistent protocols, and we had resource differences. What I want to show you in the next 5 minutes is what we've done in an attempt to move forward. Now, there are other things that I believe we have shared that have some effect on us, perhaps that we can't even identify, but here are 3 examples that we have certainly shared in the common border in San Diego. And this is one of the hospitals in Mexico City, and I think it doesn't really need any other comment. So for all of these reasons, we are in a mindset where we want to try and develop more than we ever have perhaps before solutions to these problems. Now, through the opportunity provided by the county EMS and George's office when he was public health director, and the San Diego CrossBorder Education, a UCSD, and Elizabeth Robson, the trauma center directors and nurse coordinators at UCSD, Scripps Mercy, and Sharp, and specifically Mike Size and his wife Beth, who's been involved in outreach, Frank Kennedy, and Peg Fridland from our hospital, got together with many people and initially asked the question, what could be done? Now, this is on the heels as well of a program nationally that has been introduced internationally, the ATLS program, and it was really a basis for common understanding. But it was clear that we could do more and we needed to do more. We had a meeting in the fall of the year 2000. We identified our counterparts both at the government level, many of whom are in the audience today, the pre-hospital level, many of whom are in the audience, and then physicians and nurses. And we reviewed for each other what our systems were like at the time and where we wanted to go, and created some next steps. The net result of this was to focus initially on education, and it's the CrossBorder Healthcare Initiative that allowed us to then go forward with this. And some of the examples of things that have been done, I'll just use in my concluding comments. First of all, we created physician, nursing, and pre-hospital education programs. There have been 3 specific conferences, 1 for physicians, 2 for nurses. These were all provided with voluntary faculty from both sides of the border, and again, sponsored and written by the Border Health Care Network. One idea that came up from this was to create a mini fellowship, if you will, where physicians from Mexico, in both Mexicali and Tijuana, would come and spend a 3-week fellowship. And under the leadership of Dr. Mayagoita and Dr. Mascarina, we have, using 3 hospitals, Scripps Mercy with Mike Size, Sharp Healthcare with Frank Kennedy, and UCSD with the faculty there, created an exchange system that has now trained 16 fellows. This includes a formal set of didactic sections, introduction to pre-hospital care. They take night call with us, and they get a certificate of completion. Now, the immeasurable results that's come out of that, I think, is perhaps the most important message that I have today. I think first and foremost, and you can ask those people at your table that have been part of this, we've developed a cultural respect as neighbors and professional colleagues. That's something that I don't believe existed 15 years ago. We have really developed respect for each other's abilities and knowledge. There are resource differences, but there are no differences in ability or knowledge. We've developed friendship, and we've found commitment similar on both sides of the border to the problems, and we in fact have found that we are much more alike than we are different. This has led to planning for the future. Going forward, there are a number of opportunities, additional conferences, expansion of the mini fellowships, more exchanges, creation of nursing fellowships. We've talked about hospital site reviews to help assess the resources and the needs, and peer review and sharing this perhaps with a teleconferencing network that could be set up across the border. Shared quality improvement and even prevention collaboration, those are the agendas for the future. In summary then, we really do see this as ultimately a trauma system without borders. That may not be technically feasible per se, but conceptually it's what we're at, and we're in the business of putting ourselves out of business. Thank you very much.
Thank you, Dr. Hoyt. Our next speaker is Dr. Jose Mayagoitia. Dr. Mayagoitia attained his medical degree from Universidad Autónoma de Baja California and completed his training in general surgery at the Hospital General de Mexicali. He's currently the Technical Secretary of the State Council for the Prevention of Accidents and Lesions in Baja California del Norte. Dr. Mayagoitia.
Good afternoon. The role I have today is basically to transmit what is going on in the state of Baja California, and I'm going to give an overview of how we're trying to plan on handling trauma. I first have to talk about some of the historical aspects. We have several things in the state of Baja California that make it very prone to trauma. One of them is its geography. We have an extension of land that consists of mountains, deserts, rivers, coast, great distances between urban dwellings and rural areas. Also, we have the boundary with the U.S., and this is very important because we also have aspects of demography that are affected by this. The population is on the rise, and it's young. Obviously, as it is young, it's going to be also prone to accidents. And we have an important migratory flow and also a urban distribution. From the economic aspect, we also have several problems like drug trafficking. Now, accidents and lesions are very important in our general mortality in our state. During the last 10 years, it's been the third leading cause. So we can't avoid seeing the problem. It's also the number one cause of mortality in young people. And the productive age, it's also being affected basically for the last 3 years. This obviously affects our capability of having people in their best years of their life in their work. So Baja California also, from the statistical standpoint, occupies the first place, or it's the leading state in Mexico in regarding accidents. The sites where we have the major problem are basically the same as it is all over the world. It's basically home and also on the streets, public sites, and basically where people gather to have fun or try to join other persons. We also have found out that the most frequent cause of mortality due to injuries are traffic accidents, which also is not anything different what happens all over the world, and gunshot wounds, and this may be caused also because of the increasing violence that happens in all over the world. So the conclusion is, what happens with trauma in the state of Baja California? It's obviously a serious health problem. We cannot avoid that, and we have to address this problem. So on February of the year 2000, in the city of Mexicali, I had a chat with Dave Hoyt, and I remember him asking me, what is being done in the state of Baja California regarding trauma patients? So basically, I remember that I told him, well, I'm not really sure what's being done. So let me just do some research, and I'll let you know. From there stemmed several meetings. The first one was in March of 2000, and we had this first meeting with the help of Elizabeth Santillanes-Robson, which is the program manager of the CrossBorder Healthcare Education and Leadership Network, which I think is has had a very important role on this development. And eventually, from there, we started having several other meetings until on September of 2000. These persons which are shown here, the ones on the left from the U.S. side and the ones on the right which are from the Mexico side. We eventually tried to do something about what was going on in the state of Baja California. So we decided that things had to be addressed. One of them was we needed better training, and we needed to know us a little more. We needed to get acquainted with each other. So we had a first binational conference in trauma in San Diego in the Scripps Mercy Auditorium. And I think it was a nice effort in which physicians from California and Baja California participated. I think it's for the first time we had the chance to really know each other. On February of 2001, we had the first group of general surgeons in which Dr. Mascareño is shown there, Dr. Mario Minor, and myself, along with the leaders of trauma in the county of San Diego, which are Dave Hoyt, Mike Seiss, and Frank Kennedy, along with some of their colleagues. And we had the chance, which I think it was a very unique chance for us, to get to know each other, also know how things work in this side of the border, and that motivated a change. As we were able to learn how one of the best trauma systems in the U.S. works. And also, we had the chance to see how things were done in this side of the border. I had the honor of being named as the technical secretary of the State Council of Prevention of Accidents and Lesions, and from there, basically, I had a task on my shoulders, basically trying to change how things are being addressed in my state. So what happened is I started doing my homework, which was basically developing a work plan and plan for the future, and also try to think in this, one of this task would be to develop a state trauma system in Baja California. Not only a local trauma system, but basically something that could cover all of the state. So my work plan basically will address these aspects, prevention, through education, legislation, and environment changes, which are not things that we came up along with. Those are basically the changes or the aspects that are addressed on the Committee of Trauma of the American College of Surgeons. We also have to develop a good trauma care system covering the pre-hospital, hospital, rehabilitation, and training. So, basically what this takes us to is that prevention will have to be addressed, and this will eventually make us change. If you notice the photos, you notice the cow has her restraining gadget. And if you notice the photo on the right, that's the E.T. Movie. That's 20 years ago. I think Steven Spielberg would not have liked this at this point, because all of the kids would have to have a helmet on their heads. So, you know, it took 20 years for you to change. I think that if we are realistic, it will take, well, several years before we change. I hope that not 20 years, but we're going to work very hard on this, and thank you for your attention.
Thank you, Dr. Mayagoitia. Our next speaker is Dr. Steven Waterman. Dr. Waterman is Senior Medical Epidemiologist with the Centers for Disease Control and Prevention. He's been stationed with the California Office of Binational Border Health here in San Diego for the past 3 years. He is the CDC lead for the U.S.-Mexico Border Infectious Disease Surveillance Program known as BIDS. He's board certified in pediatrics and preventive medicine, and is a member of the San Diego County Advisory Committee on Bioterrorism Preparedness. Dr. Waterman.
Thanks, George. Good afternoon. I'm pleased to be invited to discuss with this group of decision makers a topic I hope to convince you is important: the challenges in the border region to preventing and responding to infectious diseases. Infectious diseases can also pose an emergency situation for the community in the form of communicable disease outbreaks. An example would be the nationwide strawberry-associated hepatitis A outbreak several years ago, which affected a San Diego distributor and Baja California agricultural industry, and also as deliberate bioterrorist attacks, something the country now is well aware after last fall's anthrax cases is no longer just a theoretical possibility. This photo of the border crossing in El Paso, Ciudad Juarez, the second busiest crossing after San Diego, Tijuana, underscores the daily volume of persons moving back and forth. While this phenomenon stimulates the economy and commerce, it also facilitates the spread of infectious diseases such as tuberculosis and HIV in both directions. This slide portrays published CDC surveillance data showing that a variety of food, waterborne, and vaccine-preventable diseases such as hepatitis A have occurred at higher rates in U.S. border counties such as San Diego County than in non-border counties and states. The bars extending to the right of the vertical dotted line means that we're seeing excess morbidity for these diseases. Tuberculosis incidence rates are also higher in both U.S. and Mexico border states than in the interior of either nation, particularly in the highly populated California, Baja California, and Texas, Tamaulipas, Nuevo Leon regions. So the border clearly is a unique epidemiologic zone in terms of the spread of infectious diseases. Until recently, the U.S. and Mexico had no unified system to track diseases in the region. The U.S. and Mexico frequently use different disease definitions, have different availability of laboratory testing for diagnosis, and disease tracking data is not typically shared. To bridge this gap, CDC has partnered with U.S. border states and counties and with Mexico to implement the Border Infectious Disease Surveillance Program. BIDS is a network of hospitals and clinics gathering uniform disease monitoring information for a limited number of infectious disease syndromes along the border. The BIDS network is strengthening epidemiology and laboratory border infrastructure with the aim of expanding to a more comprehensive system over time to improve border infectious disease prevention and control. BIDS Sentinel sites are distributed throughout the border in sister city regions, and new sites have recently been added in Imperial County and Mexicali. BIDS to date has enhanced our ability to detect outbreaks in the border region for a number of important infectious diseases, but it's just a beginning. Recent events have underscored the need to optimize our preparedness to rapidly detect dangerous infectious diseases used as weapons and to respond effectively to control disease spread. A border-wide bioterrorism public health work group, including the BIDS network collaborators, has pointed out that the border may be considered a high-risk area vulnerable to bioterrorism because of the potential for uncoordinated response, military targets in San Diego and El Paso, the prevalence of crop dusting planes that can be used to spread infectious aerosols, and the mobility of the populations. Because of the incubation period, smallpox, for example, would likely spread from one side of the border to the other even before the disease is recognized. Border crossers could also quickly spread disease beyond border counties to metropolises like Los Angeles and Mexico City. Again, the release of an agent with its early spread may initially be silent, unlike the World Trade Center tragedy. The first cases will have to be detected by vigilance and cooperation between the medical and public health system, as was the case with the first anthrax cases last October in Florida. To illustrate this point, I'm going to summarize a tabletop scenario presented at a UCSD regional conference on bioterrorism 2 years ago. Let's imagine that the Vice President visited the southwest corner of the United States on May 1st of this year. On May 8th, the FBI notes rumors that something happened in the Southwest. On May 12th and 13th, 6 young adults are admitted with fever at University Hospital. On May 15th, 2 adults are admitted with presumptive diagnosis of chickenpox. That evening, an infectious disease specialist suspects smallpox and specimens are airshipped to CDC. May 16th, last Thursday, the CDC laboratory confirmed smallpox, pushbacks of vaccine were released, and the President announced these actions to the nation over the media. Next slide. Over the weekend and through today, 80,000 to 200,000 persons have been vaccinated. But 50 smallpox cases have been identified, and the first case has died. We can expect over the next month for smallpox to spread extensively in the U.S., Mexico, and Canada with a mortality rate of over 10%. Despite an ongoing effort to manufacture vaccines, smallpox vaccine supplies are still not sufficient to meet the demand, and severe economic and civic shock is in progress. Now, experts feel that this scenario is plausible. Our Border Bioterrorism Work Group has asked what would be the special challenges faced in the border region as San Diego and Tijuana would attempt to cope. In early discussions with Mexico epidemiologist colleagues, we agree that collaborations between the U.S. and Mexico and between California and Baja California can and should address training issues, laboratory and communications infrastructure, and environmental testing and cleanup. We're hoping to build upon this new border infectious disease surveillance system and establish capacity to monitor for clinical symptoms and syndromes consistent with diseases such as smallpox and anthrax. Early detection and timely cross-border communication are critical. Equally important, if only from the narrow perspective of avoiding missing sentinel cases, is access to medical care for migrants. Many in the audience are aware, but some may not, that a bolus of federal funding to boost public health infrastructure and preparedness for bioterrorism has been released to states just a few days ago. California, apart from Los Angeles, will receive $60 million from the CDC. The California Department of Health Services has put together a work plan to address these critical focus areas: planning, surveillance, laboratory capacity, a communications network for health advisories, risk communication to the public through the media, and education and training in several of these areas. About 75 to 80% of the funding is going to the local level, and San Diego County will receive about $3 million in CDC funds. Additional funds from the Health Resources and Services Administration, or HRSA, will be going to certain hospitals in the state. CDC provided guidance to border states to encourage addressing border issues. However, no dedicated funds for the border were designated by CDC. At the state and local level, government with advisory groups must make hard decisions about how to prioritize spending. The state work plan includes some funds at the state level for border surveillance and training and for a cross-border needs assessment of communications infrastructure for a health alert network. We hope to work in the near future with Baja California to assess how we might improve secure internet connectivity and emergency communications capacity. Border laboratory infrastructure issues are more complex and have been deferred. A number of key issues must be addressed to bolster preparedness to respond to infectious disease emergencies in the region. One is that in the health arena, it is hard for binational concerns to compete for funding without dedicated funding. I think it's important for the county as well as the state to use some of this year's and next year's supplemental federal funds to address border and binational concerns. Perhaps border counties like San Diego and Imperial should advocate for and negotiate at the federal and state levels for dedicated funding. To successfully address regional preparedness may require sharing resources with Baja California and finding mechanisms to do so, something that's been difficult in the past. A coordinated regional planning effort is critical. A surge in hospitalized patients needs to be considered in the border context. How will you assure that there will be sufficient infectious disease isolation facilities, vaccine and antibiotics to contain and limit an outbreak of smallpox or anthrax in the region? A formal agreement does not exist but is probably needed to assure both countries that critical information will be exchanged in a timely manner. Mexico's current laboratory plan calls for specimens for Baja California to be tested in Hermosillo, Sonora State, about 500 miles from Tijuana. Perhaps an agreement could be reached to share specimens with the San Diego County Public Health Laboratory for facilitated cross-border transport and testing to expedite results. I hope I've given San Diego Dialogue a useful overview of the issues and challenges to responding to infectious disease emergencies in the border region. Thank you.
Thank you, Dr. Waterman. Our final speaker is Dr. Francisco Vera Gonzalez. He's Secretary of Health, State of Baja California del Norte. Dr. Gonzalez was a federal congressman and member of the Health Commission. He acted as a medical subdirector and chief of surgery at the Hospital General in Ensenada and general surgeon at that hospital in the Institute of Security of Social Service for Government and Municipal Workers in the state of Baja. He's been president of the Medical School of Ensenada and chief of instruction and research at the institution. Besides his medical doctorate degree, he has a degree in public administration and general surgery. Dr. Francisco Vera Gonzalez.
Thank you. Good afternoon, Licenciado Eugenio Lourdes Walter, Governor of Baja California, members of San Diego Dialogue, ladies and gentlemen. Thanks to San Diego Dialogue for this invitation to present Baja California Health Program for the period 2001-2007. As resident of this area, this is most important in the world, where thousands of people cross on both directions. We share the same geographical area and, among others, the same challenges in public and environmental health. A border area where the microorganisms and pollutants don't know about visas and borders. These are the reason why la Secretaría de Salud de Baja California has a special interest in border health activities, and we are participating in the recently created U.S.-Mexico Border Health Commission. El Plan Nacional de Salud
The National 2001-2006 Health Program focuses our goals in terms of a universal health system for which 5 main action lines have been established to improve general health conditions, to reduce inequality, to ensure response in public and private systems, to guarantee financial protection, and to strengthen the health system with a special focus on public health institutions. This national health program establishes the guidelines which focus on reducing epidemiological deficits which contribute to higher mortality and morbidity rates. Where in Baja California, through our immunization campaigns and with our priority programs, we've been able to register significant progress. The strategic development guidelines in the area of the health sector of Baja California, in addition to continuing with our national health programs, have also identified as a goal to structure a basic program for health care services attuned to our epidemiological reality in Baja California, where emerging diseases occupy ever more important percentages amongst the cases of mortality, which are the result of various factors, resulting in accidents, sexually transmitted diseases, HIV/AIDS mainly, diabetes, hypertension, cancer, heart diseases, mental health problems, and especially substance abuse of all kinds. In this situation, then, in terms of health care in our state, almost 35% of the population is not registered within a private system, and it falls to the Ministry of Health to attend to these individuals. We have created a sectorial program to attend to this, where the strategic issues or agencies are the State Health Council, universal coverage, quality in healthcare, and organizational development. The Ministry of Health oversees this program and seeks to implement sectorial policies to foster professionalization and research the basic healthcare services and specific national programs, such as Healthy Communities, Leave Healthy, Return Healthy, which is a program specifically for migrants and day laborers, and other programs focused on combating substance abuse, all of which have allowed us to promote our state health program, whose goal is overall to continuously improve the health of the population of Baja California through coordinated participation of the public, social, and private sectors. It is quite clear to us that the better the coverage in terms of health services, the less the number of diseases or epidemiologically important cases, which is why the mortality cases derived from emerging health care initiatives and others require that we redesign a strategy to effectively make a difference in our health care problems by following the next strategic guidelines to reduce the deficit and to improve coverage, to confront health problems derived from non-healthy lifestyles, to foster continuous quality improvement, to promote mechanisms which provide financial protection to the community against catastrophic events in families related to health care, to promote an integrated healthcare model by implementing a sectorial perspective to foster the professionalization of people and infrastructure as well, in addition to establishing actions tending to reduce substance abuse in the community of the state through the State Council Against Addictions presided over by Mr. Lordi Walter, Governor, and also serve as the operative branch of this council, so to speak. Finally, and in summary, our goal is to provide universal coverage for the basic health care services for Baja California and improve our concept of healthy lifestyles as well as the standards of well-being and financial protection in terms of health care expenses in our community.
Muchas gracias. Thank you very much for some wonderful presentations. I'd like to just reflect a second on the lessons or points that have been made. Tremendous advances are being made in how we prevent and handle emergencies, trauma, and the occurrence of disease on both sides of the border. The border public health and emergency and trauma safety net is challenged by the occurrence of trauma and disease, both intentional and unintentional, as well as the need for resources. We know that training and coordination, collaboration and communication lead to higher performance and optimal outcomes. And we've learned that investment in public health preparedness and improved response to emergencies and injuries saves lives, preserves livelihood, and improves our quality of life here on the border. We owe a debt of gratitude to these wonderful presentations, and I would now like to invite your questions to participate in San Diego Dialogue, anything that you might wish to direct to any of our speakers or comments you might have on your mind to add to today's learning. So please, there's people here in the audience that have a great deal to say and ask questions.
Is there something in place at the border to make sure that help can get to one side or the other?
I would have to say we're in the very early stages of planning to be able to respond. We've had a number of meetings over the last few months, but there's much work to do to create a seamless response.
To me, it seems as though a key piece of this is the security element on both sides of the border. Is this, are your efforts and your dialogue being integrated with security on the military side and also on law enforcement? Because the threat of bioterrorism could happen tomorrow. And the kinds of challenges that you've just described sounds like it will take many, many months, if not years.
With the anthrax cases last fall and with increased attention to bioterrorism, there clearly has been a new partnership between medicine and public health and with the security community agencies like the FBI and INS and so forth. But there are still kinks to be worked out, and you're right. It may take months to really for those different groups which have different cultures to work together. I mean, you may have heard of some disconnects between CDC and the FBI and with the anthrax cases, but it's a key issue, and it has to be solved for us to be able to work effectively.
In Mexico,
the Secretary of Health, through the Subsecretary of Health Prevention, is preparing experts in epidemiology, and we're in contact always with, and the central level with, so that in these type of emergencies we can establish a biological guardrail, and we are, of course, in contact with California authorities.
Yes, this is a question for Baja California. My name is Lori Sunini, and I'm the border coordinator for the County of San Diego Department of Health. And in the past, there has been, under the previous administration, the Secretary of Tourism of Baja California was very active in putting together a committee to get ready for like the holidays when we knew there would be peak movement of Americans into Baja or teenagers for Halloween or something. And it was a joint committee that was driven by Tourism Secretary Tintos, but it was very effective because it had the police of San Diego and Tijuana. I see faces in the room that participated in that committee, as well as Highway Patrol. But I thought it was very unique that tourism would be one of the areas that would drive a very important thing of working for the safety in binational emergencies. And if I was wondering if that was going to be a continued commitment for Baja California.
Thank you.
Yes, we have been in contact with the Secretary of Tourism of Baja California, and the preoccupation is there to improve the possibilities for those tourists who visit us from the United States. It's our preoccupation, and the council or the committee of accidents and injuries is an example. We want to have much higher quality hospitals to give the tourists of California, not only of California, but of the whole world, the opportunity to be attended and even better here in our state.
Dr. Waterman, the multi-drug resistant tuberculosis is emerging as potentially as bad or worse a threat as HIV. Do you get a sense that we're up to speed from the American side, reaching across the border to our neighbors and working with them in this regional issue? And if not, what sort of things do you think we can do to get on top of this very, very specific and very, very dangerous threat?
There are higher rates of multi-drug resistant tuberculosis in the border region and in other parts of the country with regard to U.S. statistics. And we do have an ongoing collaboration with Mexico at the federal, state, and local level with the public health tuberculosis programs. And in fact, there was recently a major meeting and agreement with Mexico several months back in which will be created a symmetrical system of referral and counter-referral of tuberculosis patients to assure that they complete their therapy. The critical issue with drug resistance is for patients who must take antibiotics for 6 to 9 months to take those antibiotics continuously without stopping. If they stop and take the drugs intermittently, they will develop drug resistance. And so there's a new approach to TB treatment called directly observed therapy, in which patients have their doses of pills observed almost every day by health workers. And Mexico is strengthening their system, and we do now have a system which was really pioneered by San Diego County, a TB program. Dr. Kathy Mosier has created this system called Cure TB, which makes referrals to Mexico and assures that patients get hooked up with the provider with this migrating population, which is so important.
This has been a very interesting and I hope very informative for you dialogue to participate in, and congratulate the audience for your participation as well. I'd like to invite now Governor Eugenio Elorre up here to give us some closing remarks before we leave. Thank you.
I want to thank our panelists and the members of the audience who participated in today's discussion and helped us to understand the importance of working together in efforts and plans to improve public health preparedness in our binational region. As we have just heard from our distinguished panelists, disease is a human affliction that does not recognize borders, and so this is an area where we must make a very special effort to find ways to collaborate binationally. Fortunately, as we have also heard, significant efforts have been made in the last few years to improve emergency health care on both sides of the border. I am especially happy to acknowledge the new and promising binational health initiatives that are being developed, and want to assure you that my government will do everything in its power to further these efforts. There is much work to be done, but we have the means and the will to succeed in our goals. And I would like to make reference to your comment on this committee to be aware of also what we can do to the tourism and to the presence in special dates during the calendar year. We are continuing to work on this, and we are making it much more wide, encompassing it more through the presence of the Secretary of Health of our government. I think that this, as I said here, is a very good example of the importance of working together on this, in this region. The dialogue has made important progress in getting us together, but we must continue, each one of us in our field of work, to do our best to get to know more of what we can do together, to be as open as we have seen here when we have doctors from our state being trained, as we have been shown here by Dr. Hoyt. I want to thank the public institutions in this county for the possibility of having these people trained and continuing to work with all of them. Again, thank you all for joining us today, and I wish you a very happy day. And again, it's a pleasure and an honor to be presiding this. And I want to thank our friend Augie Gallego, chairman of the San Diego Dialogue, for this opportunity. Augie, it's a very good effort, very good topic, and we must do much more still on this and other opportunities we have to work together. Thank you.